of Neuro-Oncology, where we highlight recently published articles in the Journal of Neuro-Oncology. We talk about the reasons behind the studies, the results, and the relevance to the field of neuro-oncology as a whole. And so today we're super pleased to have with us two authors of a recent article reviewing really laser interstitial thermal therapy and how it may affect immunotherapy in malignant gliomas. And so I think this is a great topic. It's part of our LIT series that we've been doing with some sponsorship from Medtronic. So we appreciate their collaboration with us as well for this series and their contribution to the NREF, which is a research fund. And so I'll let you guys introduce yourselves and talk a little bit about what's going on. Typically we chat kind of informally for about 15 minutes, then we can open it up to questions and comments from the audience. So take it away.
All right, thank you so much. Randy and Nitesh, thanks for inviting us to come and give this talk. I'm Ashley Giacetin. I'm one of our neuro-oncologists here in the Department of Neurosurgery at the University of Florida. David, I'll let you introduce yourself.
I'm David Shin. I'm a PGY6 in the Department of Neurosurgery, and somehow the light at the end of the tunnel is nearby. Never thought it'd come so quickly.
Yeah, so we really appreciate being able to come here and talk with you all. I work closely with our surgeons. Miriam Rahman is our tumor surgeon who does most of the LIT as well as our glioblastoma and also has a lab here. And I work with David Tran, who's our division chief, as well as Dwayne Mitchell, who's one of our co-director of the brain tumor program here at University of Florida. We put together a couple of slides that we thought we would just kind of discuss some of the highlights of the paper itself and introducing the idea behind using LIT with immunotherapy. We can talk a little bit about our institutional experience and then hopefully open it up to questions for everyone. So the background that really makes us think about LIT for malignant gliomas is really the idea of cytoreductive treatment for deep-seated lesions for poor surgical candidates. You have those patients that come in, they're not able to get a gross total resection or debulking for that matter, and they're left as biopsy only. We think of those thalamic tumors or really deep-seated lesions where we're worried about eloquent areas that surgery is not amenable. So LIT has really become a new option for these patients, and really the technique has grown exponentially with the advent of MR thermography, allowing for accurate temperature monitoring during the procedure. Its initial use with this technology really came about with radiation necrosis, as well as epilepsy patients, and has moved its way to patients who have malignant gliomas. There's been evidence suggesting blood-brain barrier disruption also occurs, and really the group from Washington University in St. Louis, Eric Luthart, first demonstrated a temporary disruption of the blood-brain barrier within the peritumoral region of recurrent glioblastoma after they had treatment with LIT, measuring the vascular transfer constant of gadolinium contrast material from the tumor vasculature into the tumor interstitial space. That's what you're seeing in the graph on the left. As well as there's release of brain-specific factors that we see on the graph on the right, looking at preoperative and postoperative measurements of brain-specific enolase. There was quite a increase in the postoperative patients. Really, the demonstration of this has been shown to last approximately peritumoral blood-brain barrier permeability 4 to 6 weeks. And that's been shown in multiple models and really kind of guides some of the treatment approaches that we use in these patients. And this is just looking at a patient. Sorry, go ahead, Randy.
Yeah, well, I guess my question is, how far beyond the contrast enhancing boundary of the tumor? Do you have any sense, or is the literature point to that?
What we've seen as far as, we don't have it, I think we need more research on that. I don't think there's enough information yet that tells you how far beyond that area. Really, the main thought has been if you lit the area that has the enhancing lesion and you open up that blood-brain barrier, hopefully you're going to get enough concentration of the therapy that's going to have some sort of effect that's going to last longer. So, that 4 to 6 window is important because you really want to start treatment immediately for those patients, and then pick something, whether, we can talk about, some of our immunotherapy agents like pembrolizumab or nivolumab, where they're giving every 3 weeks. You want to start that as quickly as possible, so you're giving those infusions pretty early on and able to
within that window.
So, I think we need more more research to be done. I think the initial stuff has really been in that area of the enhancing lesion. We haven't really talked about giving lit to non-enhancing lesions, but I think it's something that we can consider and discuss going forward, and more research is needed for sure.
Yeah.
So delivery of the therapeutic agents into the brain is really obstructed by the blood-brain barrier. This peritumoral region is typically the location of recurrence, infiltrating tumor cells. They're likely to have intact blood-brain barrier, which exerts its own resistance to therapy. Even temozolomide, which is the backbone of our treatment for malignant gliomas in the newly diagnosed, and at times even in the recurrent setting, you think about it as a re-challenge. The CNS concentration is only about 20% of the serum concentration. If you increase the dose level that you're giving currently to try to achieve a higher CNS concentration, it'll be too toxic for patients. So even our backbone bread and butter treatment is doesn't have an effective CNS concentration that we would like it to. We know that GBM is immunologically cold. There's limited effector T cell infiltration. You have excessive energy. There's increased population of T regulatory cells and myeloid-derived suppressor cells that contribute to this really immunosuppressed patient with GBM or malignant gliomas. And lit can really potentially change the GBM from cold to hot. We know that there's a immunosuppressive effect that's seen in the tumor microenvironment. It's well documented and really further aggravated by the blood-brain barrier that limits the ready access of tumor neoantigens to the immune cell. This is a major contributor to the immune escape mechanisms by tumor cells. So, we think of the temporary post-lit disruption of the peritumoral blood-brain barrier as a potential to improve targeted delivery of immunotherapeutic agents. While you also at the same time can promote bilateral trafficking of immune cells that gain access to the ablated and subsequently inflamed tumor microenvironment. So to kind of add to, Randy, your question, our hope is that when you're when you ablate that enhancing area, the inflammation that surrounds that area, which you will have inflammation that typically it goes to the rim, there is going to be edema around that area. So it's unknown to us how much more effect you're going to have outside of that rim, but we hypothesize probably there is some sort of changes even in that flare region that you're going to have inflamed. Go ahead, sorry.
I attribute it sort of to, just to be topical, sort of to like this mRNA vaccine, right? You're going to stimulate a broad immune response to disrupted tissue within that enhancing region. And it's not just going to be a focused, targeted single protein response. It's going to be a broad kind of, combination immunoresponse against the tumor in general and all these antigens and neoantigens. So I think it's a great point. More than anything, I was just curious if there was data to how far beyond it goes. But.
Yeah, no, it's a great question. I don't think we have enough research and evidence pointing to it, but I agree with you. I mean, I think that's logically, when you think of this information, you would think it would make sense for that to happen, especially when you think of these inflamed tumor microenvironment and also the tumor-associated neoantigens that are then released into that area. You think of that there's just like a really would promote a successful tumor-specific immune reaction, and that's what we're looking for. That's what we're hoping to achieve there. So no, we agree completely with that.
Yeah.
Really, the other key points we think about is, the lit potentially we're hoping can address both of these problems. The blood-brain barrier, which is this physical barrier that really inhibits the penetration of these therapeutic options that we're trying to give to patients. And then also the immunologic suppression we were just talking about within that tumor microenvironment. In a way, we have, a modality that can then really alleviate both issues that we're faced with when we're treating these patients. Hyperthermic cell death, really this is high energy photons that are emitted from the catheter tip, near infrared wavelengths that are necessary for optimal CNS penetration. 50 degrees Celsius is what's necessary to create reversible cell death through denaturation and nuclear damage, but 90 degrees Celsius is going to result in vaporization and CO2 generation. So really the thing we have to consider is when you perform lit, there are certain temperature thresholds that are needed to reach to ensure that the appropriate effect occurs. MR thermography really allows for the precise control of temperature within the lesion while you're simultaneously preventing inadvertent damage. That way we know that the 50 degrees Celsius, you start to see the reversible cell death. But really beyond that, there's this 40 degrees Celsius window of relative safety, but we don't ever go close to 90 degrees Celsius for vaporization of tissue can occur. And it's inherently dangerous within this space in the skull that can put the patient at risk. I think from our institutional practice, unfortunately, Dr. Rahman couldn't be with us today. 70 degrees Celsius is probably with that sweet spot that people are using, but I'd have to defer to them for their technique. But really between that 50 and 90 degrees Celsius, not wanting to get too close to 90, obviously. Immunogenic cell death, really damage-associated molecular patterns are generated upon cell death. We think of ATP, heat shock proteins. These damage-associated molecular patterns result in antigen-presenting cell generation and recruitment that can lead to immunogenic cell death. Many of the chemotherapeutic agents that also release DAMPs and subsequently immunogenic cell death. However, temozolomide in murine glioma models unfortunately haven't been able to do that. What you've seen is in other solid tumors, you can see topoisomerase inhibitors and certain DNA alkylating agents been able to show this DAMPs and subsequent immunogenic cell death, but we're really looking for something more in our CNS tumors, and that's where LIT comes in as a possible option for these patients. Infrared generation of immunogenic cell death. There's infrared phototherapy has been shown to also generate these DAMPs and immunogenic cell death, and LIT can serve not only to cause the cytoreduction, but also generate these DAMPs in order to encourage a amplified synergistic immunologic reaction. This just really showing a mechanism of blood-brain barrier disruption. And the idea is, Kiatkin et al., they demonstrated that there was a temperature-dependent albumin permeability curve, and that you can actually localize it. So unilateral carotid treatments in the rat model demonstrated there was this hemispheric blood-brain barrier leakage. That's important to us because when you're thinking of this modality, you want to make sure that the area that you're treating is going to be a focal target. Obviously, you want the reaction, like we were talking about earlier, to really have a downstream effect where the inflammation surrounding that area is going to then recruit more of the immune cells to come and cause increased trafficking and a more robust response. But of course, the target you want to be focal, unilateral, and this is showing that you can have the treatment to be really localized into a ipsilateral region. Augmenting chemotherapy. The drug delivery is really via temperature-sensitive liposomes. There's been success seen in liver malignancies and also has been able to replicate as well in murine glioma models. And what the graph on the bottom is showing is just the serum GFAP seen up to 6 weeks post-LIT, which potentially indicates this window of opportunity for improvement of delivery, increased concentration of the therapy. When you look at evidence of immunologic responses post-LIT, the in situ vaccination models, they have been developed. There's been in-CVAX LIT plus synthetic dendritic cell stimulator resulted in sustained systemic anti-tumor responses. Also LIT and CTLA-4 inhibitors like ipilimumab have been producing a durable response in metastatic melanoma patients. So blood-brain barrier disruption by LIT could improve lymphovascular circulation of these tumor-associated antigens into the ipsilateral cervical chain. And when you evaluate the dendritic cell response in the pre and post-LIT setting in glioblastoma, we did this by measuring interferon gamma responses in the pre and post-LIT dendritic cells that are isolated from the PBMCs. You saw a significant increase in interferon gamma when post-LIT dendritic cells were actually exposed to the tumor lysate. And that's graph here is showing what you find is almost a stair-step approach. So it actually continues to increase during that. And that was, interesting to us to see that you had this sort of response that didn't actually augment or actually go down. It actually ended up going up in the stair-step approach. So we have, clinical trials right now that are ongoing to look at the combination of LIT and immunotherapy as well as other chemotherapy agents. This will continue to grow, I suspect. We have several different investigators who are looking at these studies. The study at the bottom with Jan Campion at WashU. This is a study that is being done at our institution as well as WashU, where we're using laser interstitial therapy as well as adjuvant pembrolizumab for those patients. So, in conclusion, just to have some slides and then open up the discussion, we know that glioblastoma is resistant to therapy, and there's multifactorial reasons. It's blood-brain barrier disruption, immunologic suppression, as well as the fact that it's a heterogeneous tumor. But the early clinical data could suggest that LIT does cause lasting disruption of blood-brain barrier. There is at least findings that there's a 6-week window, and then also increased immunologic response. With the idea, in our opinion, when you're going to combine it with immunotherapy, that you're going to cause a synergistic effect and actually amplify the responses that you're going to have with the immunotherapy. Our last slide really talks about institutional experience and kind of open up to our discussion. My feeling is when we've looked at the data and that you see the studies that come out with immunotherapy in glioblastoma in particular, in recurrent patients, pembrolizumab wasn't found to be any more effective than just, Avastin in the Checkmate study. There hasn't been enough studies looking in the newly diagnosed setting. I think what everyone understands is if you're going to use immunotherapy, you have to be able to add something else in combination. So whether it's a chemotherapy or maybe some other modality, I know SRS is being used, rearranging patients and adding pembrolizumab. But I think the one thing I like about the using LIT in this situation is, there's kind of two things. One of them is, we haven't seen, of course, it's a new modality. We haven't really seen the same side effects as you may have seen with SRS, especially if you're targeting a lesion that's near the resection cavity. We know that 80% of these tumors are recurring at the site of the original resection cavity. So you would be offering SRS essentially very near the area that was previously treated with fractionated RT. So I think LIT in that way, you would hope alleviate some of those side effects that you're going to see rearranging close to the original RT field. And then the other thing is if you think about combining immunotherapy with another chemotherapy agent, you're adding more systemic toxicity. And when you have these recurrent patients, they're typically not at the same level of health or functional status that they were when they were initially diagnosed. So they're not going to be able to tolerate maybe the same therapies you were introducing early on. Commonly what we see, and also decline in functional status. So I think the nice thing about the LIT option is that you're not introducing another systemic treatment option, but something that's actually focal targeted, and then you're able to then add your immune therapy afterwards, not having to combine it with some other option. So I like it in that way as well, and I feel like it's something that we're going to see continue to increase in its use.
Absolutely. Well, thank you guys so much. An excellent presentation. A lot of work clearly went into kind of understanding what the implications of this are. And I think number one, thank you for being part of this today, and thank you for presenting this and putting it together. I know Nitesh deals a lot with LIT. I know Rutgers has one of the earlier experiences as well with Shavar Danish, and I think he had some questions for you guys. I have a bunch as well, but we'll let him start it off.
Thanks, Randy. Thank you, guys. I think it was a great talk, and it's really exciting for me to sort of see some of this stuff. I got involved with some of the LIT work early on with Dr. Danish here at Rutgers, and to see what it's become over the last decade, it's pretty exciting. I think my question for you guys was, one sort of based on a thought is that having this sort of blood-brain barrier breakdown and having a sort of antigen presentation, et cetera. We did a tumor talk a few weeks back, or maybe perhaps a month back, where we looked at sort of serum microRNAs and how they can circulate in these tumor cases, postoperative, et cetera. Have there been other studies that looked at, let's say if you have a lesion, a GBM lesion that it's perhaps recurrent. In some cases, they may do a tissue biopsy and then swap the biopsy catheter with a laser, which is done sometimes. Is there a way to compare that sort of tissue genetic expression with what we're seeing in the peripheral serum as a sort of a quantitative measure of blood-brain barrier breakdown?
I don't think there's been, basically all the serum evaluations has been for, surrogate markers of blood-brain barrier breakdown. As we pointed out, in the study with Luthard, they looked at brain-specific enolase, our own patients that we had some other separate preliminary data. We had GFAP. So I don't know off the top of my head what the, genetic profiling of serum and, circulating lymphocytes or what have you are. The data that we also had presented was functional data showing that, we obviously, it would be ideal if when we had collected the PBMCs and, put them through the restimulation challenge for the tumor lysates, then we could also have done, genetic profile of them. I think that would be very interesting to see what that was, and specifically look at like T cell receptor profile and things along those lines. But I don't know off the top of my head if there's been an investigation into like pre-surgical or pre-lit and post-lit genetic expression within the serum.
So they have done that. They have looked at certain things when you think of neoadjuvant pembro. I know the PRIM study out of UCLA, when they looked at recurrent patients who are getting neoadjuvant pembrolizumab, one thing they looked at was CD8 T cell infiltration, and that was essentially giving the patients the checkpoint immunotherapy drug, taking them to surgery immediately afterwards. And then they did look at CD8 infiltration, and they found that to be increased in the majority of the neoadjuvant group. I haven't seen it, and I agree with David, I haven't seen anything with LIP, but certainly that would be interesting to note. I don't know what we would find initially because we're not giving it neoadjuvant, but that's also, a thought. Why not give it neoadjuvant and then give them LIT? And when you do your biopsy before you deliver the laser, that's tissue that we could collect and then analyze. I think more and more the studies that people are looking at are hoping that there is this window of opportunity to then maybe give treatment, look at the tissue so that we see if there's actually concentration of drug that's actually delivered. I know that's a big deal right now in the field, especially, neurosurgery, thinking of, how are we able to actually determine whether or not this treatment's effective.
Great, thank you guys. We did have a question from, I guess, one of the sort of audience members regarding, I think the question was asking regarding wavelengths and temperature. I do know there's a variation between the Visualase Medtronic system and the and the other systems that are currently available. Could you guys comment a little bit on that regarding wavelengths used or temperature sort of boundaries, et cetera? I can comment on the Visualase stuff if you guys have anything else from the other standpoint.
Yeah, I think I'm under the impression that both of the commercially available systems use the same 1064 nanometer wavelength. That's their near IR wavelength to generate the heat. So I don't think there's any modulation of the actual wavelength since it's being delivered constantly through the laser. So as far as I know, it's just a matter of power that and then heat generation, and then you just monitor the heat generation as opposed to some kind of specific. I think modulating the wavelength would be very unpredictable, and you're trying to make sure the treatment is uniform as
right, of course.
Well, my big question here is, right now LIT is not used really in gliomas, right? And so, we're kind of discussing this as a way to stimulate an immune response. I mean, how do you envision, the treatment algorithm for this? What is going to be, how do we bring glioma patients into the mix, and what patients specifically is this used for?
No, that's a great question, Randy. I think it's, especially when you're starting out, just like you said, your center is just, getting it on board, and then you're going to want to start recruiting patients and thinking about how you want to use it. I think it's going to be tough, right? So if you have a patient that you feel like the lesion is in a good spot to resect, you should consider that. And that should still be done in recurrent glioblastoma. I think if it's accessible, resect. We're seeing some, good data coming out from the neoadjuvant pembro, and I think that's, one option, or at least considering a clinical trial, but resection seems to make the most sense. If you have a recurrent study and they qualify, we should definitely think of that as well. I think it's going to be important for the lesions that are maybe a little bit too deep, a little bit outside of the comfort of wanting to go in and have another large resection. Patient functional status, are they going to be able to tolerate a large procedure? For those patients where we were going to consider biopsy initially to get tissue diagnosis, I think thinking of lit makes sense. Even if we were considering stereotactic radiosurgery. We don't actually use SRS at our institution for recurrent GBM all that much. I think there's really only, it's a case-by-case basis. I know a lot of centers do consider it. We've almost gone the other way and now just think of lit in those situations. So I think where it's going to compete is with radiosurgery, and I think that it has a good role when you have those lesions that are close to the original resection cavity, not somewhere that you feel like is going to be easily accessible for surgery. We should consider it. The other option that, this is, it's going to take a little bit of leap of faith, but I know centers are doing, I know Peter Fetchy's been doing this at Duke as well. I did my fellowship at Duke, so I got to work with Peter Fetchy there. And I know that he's been looking at this for even newly diagnosed patients where they have, maybe a lesion that's, in the thalamus or, somewhere where you can be a biopsy only candidate. If the size is right, consider them for lit at that point, and then go ahead with radiation and temozolomide with the hope that you're at least, stimulating and disrupting that blood-brain barrier and also trying to cause necrosis while you're treating the patient as opposed to just giving the biopsy. Yeah, we've tried it. We just haven't done a lot of it. So you're right.
Yeah.
I mean, it's kind of a new...
Listen, I agree with you. And I have conversations every time I get one of those, specifically a deep-seated, like a thalamic or a basal ganglia lesion into glioma, and there's nothing you can really do other than biopsy. Someone always throws out laser it. And I just don't think there's enough out there, right? Large series that'll tell you that it's the right or wrong thing to do. But the nice thing is you're talking about a stab incision, right? You're not talking about wound breakdown with chemotherapy and radiation. You can really initiate therapy, like you said, within that 4-week mark safely, and get people treated rapidly. And if there is, an immunopriming event, or you're using an immunotherapy along with it, it makes a ton of sense. And it's at least giving an option to people who didn't necessarily have an option previously, right?
Yeah.
And so I think, I think very, very enticing work. I think it's, it's charming. And, my only other question then is, let's say you guys obviously are proceeding and studying this and interested in creating an immune response. Let's say you find one. How do we do this with the cases that are like a big right frontal glioma where you're doing a gross total resection? How do you stimulate the cavity now to induce the same, immunologic sensitivity or sensitization?
It's a perfect question. I don't know if we have the right answer now, but I can tell you, from internal discussions that we've had, the one consideration is if you have a large lesion that you can resect, they need to recover. Why not get a, post-operative scan 4 to 6 weeks out, see if there's any kind of residual disease and just target it. I mean, there's a lot of times where you'll do surgery and you say, listen, I got everything I could see. You get the post-op imaging, and there was probably a little bit of persistent enhancement there that we consider, okay, there's probably some disease there. It doesn't make sense for us to want to go back in there and get it, or it was too close, we had to leave it. That'd be a perfect situation to maybe consider lit. So then you're, debulking, you're basically cytoreductive with the resection, near total resection, giving them lit, then considering, some sort of immune therapy. I think you really have, done a good benefit for those patients.
What do you think matters more? Is it the blood-brain barrier breakdown or the tissue injury with the heat? It's speculative, I know, but I'm just curious what you guys think. Because then, listen, I don't want to discredit what you guys have done. I think it's fantastic. I think it's a very, very logical next step. But what about things like focused ultrasound at that point, or just, using intraarterial mannitol and opening the blood-brain barrier, right? Yeah. In a post-resection cavity? I don't think anyone knows. I'm putting you on the spot a little bit, and I apologize. But
no, that's okay. If I had to guess, I think it is opening the blood-brain barrier to increase therapeutic concentration. And I go back to there was a +1 article by Eric Luthard and then David Tran, our oncology chief here in Neuro-Oncology, where they looked at giving laser ablation and then treated the patients with doxorubicin. Yeah. And they found some signals, some trend towards benefit for those patients, where doxo in the lab is actually very, it's effective against glioblastoma. But in vivo it has
in real life, yeah.
So that makes me think that there is, and again, I'm just speculating, but I would be in the bucket of voting for the blood-brain barrier.
Yeah.
I would
Thanks.
say that I think the unique aspect, you mentioned focused ultrasound and these other things that can selectively open the blood-brain barrier, but if all of those are equal, the unique advantage I think LIT provides theoretically is the tumor-associated antigen release and the lymphovascular proliferation and all these things that the other things don't necessarily achieve, in getting the immune response or attempting to modulate the immune response in some way, shape, or form. So, if everything is equal, then sure, we might as well. Focus ultrasound is obviously not invasive, and it's much safer than sticking a laser probe into someone's brain. But, I'd like to think that all of this, theoretical data tells us that we're going to get a good survival benefit, not only because of the blood-brain barrier, but also because we're priming the immune system and getting it to see these antigens that would not normally see in a typical scenario. So those are my thoughts.
Absolutely. I agree with both of you. I think, I think there's got to be an answer. Someone's got to figure it out at some point. And so I hope everything's right, truthfully. But anyway, we're at our 30-minute mark. We keep it short and sweet so people stay interested. I sincerely appreciate your guys' time. Fantastic talk, fantastic discussion, great contribution to the journal and literature. And we look forward to having you guys back once you figure it all out and put it in the JNO. And so we're going to take off. We're going to take off next week. Happy holidays to everyone. We'll be back January sometime early. And everyone stay safe, stay vigilant. Good luck out there. And thanks again.
Thank you.
Take care, guys.
Have
Thanks.
a great night. Take care. Bye.
Thanks, Randy.